I will introduce myself. My name is Talaat Atassi. I'm an orthopedic consultant surgeon at Salford Royal Hospital. I'll be taking some questions as I go along and maybe towards the end. You wonder what the meeting is about today. It's really effectively give you a flavor of what the doctor's life look like, what I've done to become a doctor, to become a surgeon, how that changed my life, and what would you expect to see as you go along with your life with this type of career. So I'm going to share a presentation with you. Can you all see it?
Yep, we can see it.
Okay. All right, so probably about half an hour presentation. Feel free to raise your hands, or if you feel make more interactive towards the end of the session, that's absolutely fine. So let's get the presentation going. This is me. I was a little child in a country called Syria, long time ago. I came from Syria to UK in 1998. It's probably about 3,000-mile journey. The plan was to stay for 3-4 years, and here it goes, still in UK, and that's me of probably 40-odd years. My education, I was grown up in a city called Homs. It's about 1 million population at that time, which was a sizable city. This is my sizable high school, quite prestigious, and this is a gate which I always remember very well, best times of my life in this school. I did my medical school in Damascus, and Damascus was unique at the time because it did teach the medical stuff and all the terminology uniquely in Arabic language. So let's say you've got these muscles in Latin, we've got completely different names in Arabic. That wasn't an easy to change. Yes, we read it in the books in English, but to be honest, we never pronounce it this way. So it was a bit of a challenge when I came here, but it's only one small challenge within many. My career as an orthopedic surgeon started in Syria. This is one of the hospitals I worked in. My boss on the left-hand side was of the really well-known surgeons, team of surgeons, surgical assistants, anesthetists, scrub staff. We all work well. I spent very, very good 4 years in this hospital. When I came to UK, I moved from different places. The best place I ever worked in was Queen Medical Center in Nottingham. This was evolving as level 1 trauma center at that time. It's a large campus, lots of professorships, very academic unit, very, very structured work, and really did trauma and more elective work. And then I moved to Royal London Hospital, again level 1 trauma center in London. And this is the top one is the old building, which the face still showing. Now they get a really massive build with helipad on top. I worked in Coventry University Hospital, again trauma center with busy elective work, and I spent some time at Norfolk and Knowledge doing shoulder fellowship to do my shoulder surgery. My current hospital, or a group of hospitals, as Matthew said, Northcare Alliance Group. My main base is at Salford Royal, which was separate trust. This is the main face of the building, and this on the back is what's getting built at the moment. It will be ready in about probably 18 months' time with the new theaters, trauma ward, helipad for helicopter to bring more trauma patients in. So we'll be level 1 trauma center. We're already quite busy, we'll be even more busy later on. So what is orthopedic surgery? Probably ask yourself the question. In this picture, you could see some people doing surgery in maybe medieval times, and the main people used to do surgery used to be the barbers. And then he established a company called the Company of Barbers Surgeons in 1540. Then the Royal College of Surgeons and Barbers formed, then it got now Royal College of Surgeons. Orthopedic surgery involved all the odd stuff from surgery to bone setting, i.e. putting broken bones together, and applying splints. So you wonder what the difference between the surgeon and bone setter in that sense. Then doctors took over the work and become more scientific, more evidence-based, and working on judgment and decision making before more technologies start kicking in. And then you got the surgeon, and the surgical field widened and widened with a lot of varieties, with massive involvement in technology last 20, even last 10 years. So our job includes fracture surgery. So if you can all look at this picture. Anyone can raise a hand and tell me which is the normal side, which is the abnormal side. Can you look? So on the left-hand side, you've got the broken hip, and this is one of the most common injuries as hip fracture. It really happens mostly in older people. When we get older and get soft bone, we call that osteoporosis. It could be terminal event if the patient doesn't get fixed early and get out of bed, because if you keep an old patient in a bed, they will get what we call pressure sores, chest infections, clots on the legs. They don't really survive very well and become ill very quickly. Hence what we do, we fix them with plate and screws, pretty strong fixation, and get them up and about as soon as possible. We currently aim to do that within 36 hours to allow some optimization for patients, make sure they are fit and having the right medications before an operation. Then we get teams of doctors called orthogeriatric, or really physicians look after elderly patients on the orthopedic ward. Other injuries, one like this, and you can see the difference between what we call a fracture in the previous picture and a dislocation. The dislocation is when the joints come apart, so two bones separated together. You would imagine if I put these bones back together, the leg will be straight, but to really get to that stage, you must have torn a lot of ligaments. You may well have damaged the pipe in the back of the knee, the artery, the vessel, and that can get blocked. You may well stretch the nerve and cause weakness in the foot. So injuring the bones and joint is not just a bone and joint injury. It involves all what we call the soft tissue and vital structures around. This is one of the very bad fractures in the elbow joint. You could see bits and pieces broken. That will make the joint very unstable and requires specific surgery to get that fixed, also to get that joint going. So fracture surgery involved putting plate and screws and pins in the bone. It could putting something called external fixator or scaffolding to put the bone together, and we use it in certain conditions when the soft tissues are all damaged and we don't want to get infection in the plate. So probably not very dissimilar to what joiners can do, or carpenters when they join two bits together. But if you are a joiner, if you get a hammer in your hand, everything will look like a nail. In surgery, it's not the same. Not every fracture needs to be fixed. Not every fracture fixed the same way. So if you have a hammer, not everything looks like a nail. So I'll give you this example. This is a three-dimensional picture taken by CT scan and reformat thanks to the technology. It's smashed elbow into several pieces. And to put that together, it's not just take the patient to theatre and open his arm up to plate and screws. It does require a lot of planning. And we plan, we trace the fractures, we build it together now on a software, and imagine that it's now all together and decide what plate, what screws, which angle, which order each screw goes through, and which nerve comes which way. So get ready plan. And we call it failure to plan is a plan for failure. So like on an airplane, if your pilot doesn't have a plan, the operation will fail, and that what make difference between a really good surgeon and a better surgeon. So you aim during the surgery to get all the nerves out of the way, you open the muscles up, you bolt the bones together, put plate and screws, and then what you want is really strong fixation to allow that elbow to move, because if you stick it in plaster, it will get really, really stiff. We got something different now from fracture surgery. you've got what we call elective orthopedic surgery. So examples probably here of joint replacement surgery or arthroplasty. So when people get older, they get arthritis in the joint, then they will have false joints put in. Keyhole surgery, or what we call it arthroscopy. And then, interestingly now, in the past, when surgeon used to be surgeon, they used to operate on hand, hip, chest, abdomen, head. Then we have that subspecialty of orthopedic surgery. Now, even within orthopedic surgery, we work within subspecialty teams. Got spinal surgeons, got hip surgeon, knee surgeon. I do shoulders as shoulder surgeon, hands separate specialty and foot and ankle. And you never know, by the time you get to medical school and graduate, you might be specialized in a finger or in a specific right hand of the patient, or the surgeon for the left hand. You never know. But this is what the example currently at the moment. This is a knee replacement. You see two bits of metal and there is a space in the middle which has a plastic bit in. And when the knee starts bending, there is no clicking and grinding and arthritis. This is an artificial hip joint. So you see the socket with the metal and a bit of plastic in between. And then you get the head of the femur. And then you got to call the stem that goes inside the femur. A very, very successful operation, invented in the 1960s, early 70s by Sir Charlie. Then we get to the shoulder replacement. If you look at the picture on the left-hand side, you could see how the bone is really seized together, bone rubbing on bone. The bone is not anymore smooth, and that was very painful. And then you have different type of joint replacement. The one in the middle, what we call anatomical. So you create the ball where the ball is, and you put the socket, which is a plastic socket here. On this side, if you think carefully, you'd see it's interesting. The ball is sitting on this side. Why the socket sitting on this side? And why we do this in this case? Because in different fractures, the tendon that move that shoulder and rotate it is deficient. And if you got deficient muscle, if you do this, that ball will start rocking up and down, and that would ruin the joint. So someone clever created this. We call reverse polarity shoulder replacement, and that's relying on a different type of muscle outside the shoulder. To get to that point and replace the shoulder, what we do, my practice, there's something called a CT scan, 3-dimension. We'll get to the software. We will take certain slices, measure the implant, and decide what base plate goes where, and the inclination of each component, what they call the contact surface area. Bone is already, the metal sitting on bone very well, and the alignment is good. Now future, and it started now recently to get to that. You get this, augmented reality. So we call it blueprint, this company call it. Effectively, you have this on, and you would see this in front of you, and you obviously it's all pre-fed on the computer, the patient size, and you decide where to go and where to put it. A very interesting field to come. I think your generation will be looking forward to do this. Arthroscopic surgery, which is keyhole surgery, and that's me recently operating. You could see on the right hand side, that's a camera. It shows you far more than an open surgery. That in my hand there is the camera. The clever part of it, the lens is like 30 degrees to the side, so when you rotate it, you can look bigger picture. There's a lot of stuff here, coming tubes, water pressure, special instruments to heat or to burn dead tissues. And then you get what we call suture repair for a torn rotator cuff. So the tendon in the joint was torn. And I put this is some special suture material. This is type of plastic screws, call them suture anchors, and they sit within the bone. So you repair the tendon back to the bone. Very smart, very clever, and very interesting. So, as a surgery, this is a type of surgery I would do in my life, or my last few days. A trauma, fractures, arthroscopy. Now, what else I would do? Something probably that will have longer impact and probably last longer, hopefully after my lifetime. Education. So very important part of any doctor's life, I believe, would be education. You need to bring another generation of doctors to look after you when you grow up, or after your kids. But training in surgery in particular is very important. So education, training, coaching, external teaching on courses. So I teach undergraduate medical students. I teach surgical trainees, so doctors doing surgery, supervise them. I look after junior doctors at different stages, and I coach them and supervise them, make sure they're progressing well. I do what I call appraisals and assessment for my consultant colleagues and other colleagues, and what we call continuous improvement, or CPD. I teach on external courses, degree in trauma. So this picture is from Salford Royal Mayo Building. These are medical students year 4, and they're learning about certain conditions, the joint, and learning how to examine hip joint in this picture. Giving some presentation about knee pathologies and knee anatomy and examination. So if you are after more excitement, it's something I choose to, but you don't have to, but you can get involved in all major trauma. So leading on trauma. There's something called war zone surgery, if you are interested. There is a humanitarian medicine, not necessarily as a surgeon, but any doctor can get involved if you really want to take that path. So now I got some pictures coming up. If you don't feel like looking, just probably look away or just switch your screen for a few slides. So this picture is from a book. It's called Advanced Trauma Life Support. I have been teaching on this course, which is organized by the Royal College of England and originally designed in America since 2007. So effectively, when you get a patient who's got multiple injuries like head injury, chest, abdomen, broken bones, he can't breathe, he could have broken spine, how to deal with a patient in one go. So major trauma, it could be one patient with multiple injuries, head, chest, abdomen, pelvis, spine, limbs, any of those. The more severe is the injury, the more likely the patient will not survive. And your job in the first golden hour is to try to get the ship to shore, damage control, get the patient resuscitated, fill them with fluid, make sure he's breathing well, get good oxygenation, good blood pressure. Then you start fixing them after that. Could suddenly get multiple patients, road traffic accident, get 3 or 4 patients or 5 patients thrown at you at once. And you are a trauma center, so you need to be equipped to have multiple teams, what we call trauma teams. Can get multiple casualties. We all remember the Manchester bombing. Sadly, major incidents happen. We all have to be prepared. You can get multiple casualties in war zone or natural disasters like earthquakes. And UK is well known for having teams that goes overseas to help with natural disasters and also with war zone surgery. I don't know if any of you watch this film, but this is a movie, it's not real life. Someone has got trapped air in his chest, squeezing the lung, cannot breathe properly, and the way what we call vein flow cannula. I'm not going to give the name away for a few seconds. Then it's called The Three Kings, it's a well-known movie. We still do this in real life. We teach on a course, probably a different place of the chest now. We put the cannula off on the side. So this is how we work in A&E, working with the trauma team. You get anesthetist looking after the airway. You've got surgeons, team leader, you got nurses. One should be stepping back and direct the team what to do and lead the show. They call that trauma team leader. So one person to have his hands off the deck, standing back and leading the team to make the patient, look after the patient. This picture from A&E at Salford Royal. The patient brought in. The orange box on the leg indicates probably he's got a broken leg. The collar around the neck, he's got protect the spine in case he's got a broken spine. You see bandage around the pelvis in case his pelvis is broken and it's bleeding quite a lot. That will stop the bleeding from happening. The patient get to this area here. You got the team looking after them. They take vital signs, they give them fluid, maybe bloods. Then they go to CT scan, will give you 3-dimensional image to the body from head to pelvis and see if there's internal bleed, any broken spine, any broken legs, and then you call the subspecialties. You will get general surgeon, a neurosurgeon, orthopedic surgeon, whatever is necessary. Now again, we get to probably the ugly part of the life, which is war zone surgery. I've been in missions to Syria with the unfortunate situation evolving. I've been a few times already, and the scenes are like this. You see a patient with multiple injuries crushed. You see there's a tourniquet around the leg, stopping the leg from bleeding. The leg is broken. You'll get the patient get tube in to get them to breathe. You'll get fluid. I think this guy, his hands on, try and get ready to resuscitate and do some heart massage. I can't remember if that patient survived or not. Probably some more pictures here. If again you don't feel like looking, don't look. But this is an X-ray of someone who had a closed range gunshot wound, actually a high projectile area. The gunshot gone through his elbow, just through the humerus, through the nerve, through the artery, and created big area or big deficient area of skin and muscles. I remember spending probably at least 10-12 hours operating on this guy. I was on my own pretty much as a main surgeon. I had to deal with everything in one of the field hospitals. This is an external fixator to stabilize the area. Have to take all the tissues out, not necessarily all the metal, but the main big ones. You repair the artery, so you get vessel with a patch of vein, get the circulation going, tuck the nerve together, and then open some sort of skin flap, so rotated the flap over to cover the artery so it doesn't get dry and clot again. And then we put the bandage on, and the patient will survive until he get all the soft tissue covered, then back probably could have a fixation with different device later on, get the bone to heal. That's another guy who's got really explosive run through the proximal femur, top of thigh. Again, he damaged muscles, he damaged artery. We get the vascular surgeon, he repaired the artery for him, and I put what I call external fixator, because if I don't fix the bone, the whole repair of the artery will fall apart. And then he will require more complex surgery to get that area to fill up with a new bone. Now, if you look on the left-hand side, it's a proper hospital, which I worked in on a day where was a raid on a bakery. Very sad day. We've been called from hospital to another hospital. Lots of casualties on the floor, children, adult people with big legs and heavy patients, untrained staff, people really just trying to learn to do something. Initially, I start guiding the patient and run the show as to my leader and assess the patient and tell each member of the team how to deal with this patient. Then I get, for example, this patient, his leg was all over the place. He had a tube in his mouth, was not feeling anything. I end up doing the operation on the floor, putting called external fixation, similar to the one you had before, then get them to the hospital later and do start operating on. Unfortunately, 2 months later, came back on mission to the same area, and this hospital was targeted with missiles, and half the building disappeared, and the rest of the building now rendered useless. Operating different parts of the body, assisting general surgeon, assisting head and neck surgeons. You get these headlights in case you run out of electricity like this one. My role in this time, I was holding the light torch really for the surgeon to be able to operate because the generator ran out. See the staff in war zone surgery, totally exhausted. You feel really humbled when you look at them. They sleep on the floor. They fall asleep halfway through sometimes, and you get another member of the team to take over. Totally exhausted. So war zone surgery is not for everyone, but it is something here you feel the best time of your life when you do this, and the worst time when you leave these guys and leave and go away. Part of the travel will be humanitarian missions. We set up hospitals. We started a new built hospital on that right-hand side. Now it become like a university type hospital. It started from scratch, from the tiles, and after I left within years, it's become super specialist center, doing anything from head surgery to eye surgery to spine, and all the technology from arthroscopy to CT scan. the left-hand side, really, I was transporting back of a truck from one hospital to another. Away from this, teaching on external courses. This is a course organized by Mr. David Knott, the guy over there. He's got his own foundation. He's got the most experience in war zone surgery. Very well-known guy. Managed to sit up in one of the hospitals in the border, in one of the universities in the borders in Turkey. Called this is hostile environment training. You see the operating here. This is a plastic surgeon as a professor showing us how to do flaps on a sheep. So this is how to get muscle from one end, but on the other end to close a big gap on the chest or get certificates. And this is the dean of the university. It took me to the old days, probably 10, 15 years ago, when I used to go to Syria and teach on what we call similar to the ATS course mentioned earlier. You take makeup, you create casualties, like come with complete different scenarios, hit by trucks, falling off trees, stab wounds. You teach how to deal with the airway, how to deal with the breathing, with the circulation, fill them up with blood, and how to make them survive for the first golden hour. So, from my perspective, what makes orthopedic surgery interesting? A variety of options. So, when you get into the medical field, obviously, like I have many specialties from medical to surgical to non-surgical to what I call subclinical or sitting in the lab or behind the screens. Even you get surgery, you got to choose different type of surgery. For me, orthopedic surgery was interested since I was medical school year 3 or 4. When I come across the material, I like it. Lots of anatomy, lot of biomechanics and dynamics. I didn't imagine that I will be subspecializing to that degree in the future. In my days, when I graduated, the surgeon, orthopedic surgeon, used to do anything from hand, hip, knee. I did even disc surgery, spine, and everything. But last years, it just get more and more subspecialized with more technology coming on board or more sophisticated diagnosis coming in. So the more you specialize, the better you get at it. So wide variety of options you can choose from after you finish your general orthopedic training. You get lots of manual and dexterity skills. There's a lot of tools and technology, if you like, doing hardware from plate screws, joint, to really more of a game remote control type work, which is arthroscopy, requires a lot of dexterity and hands-on. You've got a lot of planning and mental judgment and decision making, when to operate and when not to operate, what type of operation to suit this patient. Will the patient have good outcome, not have good outcome? And with the beauty about surgery, this type of surgery, like you fix a patient and they get better within a few weeks to a few months, and then you really have very rewarding. And some specialties which I didn't take, the patients will coming backward and forth. You make their life easier by operating or treating them, but obviously the outcome quite late down the line. So in orthopedics, you got some early outcome. Patient satisfaction is good, and really the key message here, if you become a doctor one day, it's about managing patient expectation. If the patient expectation is higher than what you can offer them, they will be disappointed even when you feel you've done a good job. So really managing patient expectation is a key thing. It could be saving lives if you, even in the set of the urban community, if you've got someone with a pelvis fracture and just apply a binder or external fixator, stop them from bleeding. If you operate on a hip fracture early enough, you save the patient from dying. If you go to more disastrous zone, you could be saving lives at more critical time. Education training is really the key for me. I've been in education training since probably for the last 15, 20 years. I always consider it a vital part of any job as a doctor. If you train a surgeon or a group of surgeons to work or train doctors to become good doctors, you'll have far more impact than operating on a number of patients and give them good outcome of surgery or treatment. Self-satisfaction comes at the end of the day after a long day or after long years when you really make your patient happy. As a doctor, you will not always make 100% of the patients happy, but you will do your best, and the patient, you know that you've done your best. But the more gray hair you've got, probably the more wise you become and the more choosy in what patient benefit, probably less aggressive with surgery or more more choosing type of surgery. But with the evolution of technology, certainly cell satisfaction is getting very good because you get really better outcome than before. So here we go. Already for me, this is not lifetime story, it's just an example of someone who was really groomed to become a doctor, and he'd like to become a doctor. When he became a doctor, he didn't think one day his life would look like this. All what you think when you apply for medical school: I want to be a doctor, I want to have a healthy patient, I want to have a decent lifestyle, predictable job market, I can get some income. But you never know when you get to your specialty what doors could be opened for you and what variation of the work you could have. So if you think probably one day to become orthopedic surgeon, for example, you need to think backwards and say what type of jobs I want to do. Do I need to be a doctor really? Do I need to be in hospital based? Do I need to be based community like a GP? If I decide to become a doctor, what qualification I need, and when I am in medical school, what topics I need to concentrate on, research, etc. And wait, you'll be back, get your A level, and decide you want to be take A level, B Tech for some other type of work, or T level, and then you have the right GCSE for that. So this is the end of the presentation. I'm quite happy to take any questions from you. I hope you found this enjoyable and useful. So happy to take any question. The presentation is finished. Any hands up?
If it's okay, could I ask a question?
If you just give me your name. So I know.
So it's Matthew Wood. I obviously work at the trust. So you referenced technology, Joe, going into the future and how things may change. I was wondering what, during your time as an orthopaedic surgeon, maybe some changes throughout that time?
Yes. So my days, I remember when we start doing arthroscopic surgery, for example. Now you see all that big screen in front of you I showed you earlier with all the gadgets. We have the first present in Syria coming from Japan, and they give you the scope, which is like a tube and an eyelet, and one holding the eyelet to your eye, and one you operating with your hands. Very weird. Then you got this screen. Knee arthroscopy was the simple one to do, just trimming some meniscus out was a big thing. We did have some laser technology coming in and faded away. Joint replacement, the instrumentation 15, 20, 30 years ago, we still have them on a shelf. Obviously, they look a bit more brutal, but they did the job. The instrumentation keep evolving. Technology in trauma, we had a lot of stuff coming in trauma. The type of plate and screws, they shape it exactly matching the bone, we call anatomical plate. We had, the highly technical CT and MRI scans and investigations. So I noted a lot of evolution, even with the organization of the work. I was in Nottingham when the first time started arranging something called hubs and spokes. So 15 years ago, there was nothing called trauma centers. All hospitals take any trauma. Now major trauma has to go to trauma center. So it's not only technology evolved, even the way the work is done is evolved.
Okay, thank you for that. So one question in chat, what are the best and worst parts of your speciality? So
best part probably I've told you about the really number of things. Best part for me is in education and training. I love it. Managing acute stuff like saving patients' life, whether it's in trauma and here or in a war zone surgery. Love it. The difficult part of it is really balancing your life and work. Could be difficult. You live with your work, and probably hitting too much on your personal life a lot of times. You're probably seeing the first picture holding the phone, probably that might be a hospital phone call. But as a surgeon, as an acute surgery, you probably the job could dominate your personal life to a certain extent. surgery not always 100% successful, and when the surgery doesn't achieve what you wanted to achieve, you don't feel very satisfied. But complications can happen with medications or surgery, and then again, as a doctor, you will always feel happy when you get successful treatment, and on the occasion you don't have the successful treatment, you don't feel happy overall.
Thank you. As someone interested in humanitarian work, what kind of qualities do you need?
Quality as a person, you need to be first thing as a team player. So working in a humanitarian field, you can't do it solo on your own. Communication is an essence. You need to be a good communicator, speaking to other people. You don't have to be surgeon. So humanitarian work, you go with the Red Cross in Geneva. They organize a lot of courses on wound management, etc. Also, they organize courses for nurses, for doctoral organizations. You can equip hospitals. You can be even non-doctor to work in the humanitarian field. But there is a lot of humanitarian organization based in the UK. You can approach them. They will put you through certain channels. You can have a flavor and tester, but mainly the teamwork and the communication and the dedication. It's not something you just want to go on a short term and leave and go. You wouldn't feel happy with that.
Okay, so how do you manage it mentally when a patient passes away?
It is the difficult question. It is something you learn as you go along. We take part of the medical education how to break bad news, but when the patient passes away, it is stressful. Let's say a surgeon operating on a patient and they had a problem with the patient dies expectedly or unexpectedly. In the UK, we have a very good system. You get the support team. First thing, they also speak to the relative, they speak to the doctor, make sure it's all right. We can't say we get used to it because you never get used to it, but it's always difficult. But it's something become part of your job and part of your life, is facing death or facing serious complications. And this is one of really being a human, we have to live with it.
Thank you. Describe your most successful medical case to date. What factors contributed to your success?
Interesting. Yeah. Really managing polytrauma patients, what we call, and this is not one-off, this is quite frequent. So you get a patient falling off a bridge or hit by a car, and they come to A&E, their blood pressure is very low, they really can't breathe. You get them managed what we call the ABCD approach. You run a team of physicians around you. You get their airway done, you get their blood transfusion, you put the splints and the bandages, and within half an hour the patient blood pressure is back to normal and he starts breathing. And you take them to theatre next day, you do the right operation for them. And I remember a day when there is a patient, I took him to theatre after all this preparation. We started 8 o'clock in the morning and finished about probably 8 or 9 o'clock in the evening, fixed 3 or 4 long bones in him. And the guy went to ICU for only 1 or 2 nights. Walk out of ICU on crutches. I've seen him in the clinic within 6 weeks and absolutely making excellent recovery after severe multiple fractures. So when you got the right setup and the right environment, you can have a really good outcome.
Thank you. So what are your biggest challenges of being a doctor?
Probably I'm feeding myself on this one, but the challenge is keeping the balance between your personal life and your work. I think that's a main challenge. Obviously, at some stage of your life, your career will be the first priority of your life, but when you start having family and children, and then the balance become more difficult. Training in UK in particular as a surgeon is pretty long, got lots of more years comparing to maybe America or Europe. By the time you become a consultant, if you're lucky, becoming your probably mid-30s. but that may probably good 10, 15 years of training. With a family and kids, you'll find that challenging. So the message is you need to love what you do, because it's going to take a good chunk of your life.
How do you prepare to tell patients bad news?
This is a skill every doctor should learn. We learn it and we teach it. It's probably difficult to explain and summarize here, but there are certain sessions to teach junior doctors how to break bad news. It's part actually of qualification as a doctor and a qualification as a surgeon. So you will be trained to do it. It's not for anyone to do it, but you'll be trained.
What are some of the things that you wish you knew before starting your career in medicine?
Interesting question. I can't say probably I would have to change my mind, to be honest. I still probably go for medicine to start with. I would still go for orthopedic surgery, but if we'd be able to know what the future is, probably we adjusted something. Maybe we've done probably more research. I trained myself more research. That probably can make my life a bit easier when I apply for jobs, for example. But there's many elements, obviously. If you know well ahead, if you plan well ahead, you make your life easy. But I don't think there was anything in particular I would know that would have changed my mind from becoming a doctor. Probably the other way around. If I know more, probably more likely to be a doctor.
Okay, thank you. How much mobility do surgeries you mentioned, like the hip replacement, leave the patients with?
Oh, excellent. Hip replacement is one of the most successful orthopedic operations in terms of patient satisfaction. Patients come to you with a lot of pain, they cannot sleep, they cannot walk properly, often they use crutches or walking stick, and within a day or two they are on their feet. Obviously the leg will be sore and swollen, but usually within weeks they are back to walking very well. Arthroplasty, i.e. joint replacement surgery, is a very, very good procedure for pain relief, but comparing to other parts of the body, probably because the hip is quite deep in, it get more patient satisfaction comparing to knee or shoulder.
So how often do you get exams as a doctor?
Oh, good questions. I think I lost count, the answer. I need to prepare a lot of exams. The last exam I've done probably in 2007. Yeah, probably it was nearly 40. About that, probably the last exam, but you need to prepare to take exams as you go along. Doctor's life is all about continuous training. I mean, in UK, even after you reach the level you want, either a GP or a consultant or a specialist, you have to have something called revalidation. Our life in UK is easier than United States. So, for example, we do revalidation just by doing appraisals and collect them every 5 years, doing some courses. In America, every 10 years, you have to redo your specialty exam once again. Even become, if you want to work in your 60s, you still have to take the exams. So you need to be exam friendly, put it that way, to become a doctor.
What part of your job gives you the most satisfaction?
It will be the education part. Yeah, for sure.
How often do you get to carry out research as a doctor, and do you work on it individually or in groups?
Doing research is better done in institution. So I did try to do a lot of research, but you would see it depends on the facilities. For example, in Wise and Queen Medical Center in Nottingham, where the department had a very good research unit. We have statisticians based in the department. We had research people, and you press the button of the computer, they give you massive data to work on and produce research. If you are to collect the data yourself and organize it and write it, just take ages. But research needed training, it needs a setup, it needs academic unit. You don't have to do it as a doctor, but often when you apply for jobs, they will look at your publication and your research portfolio. And the more you have, the more points you will get. In academic institutions, university hospitals, they all like people with research background, not necessarily professors or done degrees in research, but they need to show interest in research.
And the final question, do you have any regrets in your career?
No, I wouldn't use that word, to be honest, no. I'm quite happy, I think, with my career.
Okay, thank you. There aren't any more questions in chat, so I suppose we'll give it another minute if any more come through.
I think I've asked the question a few times, what would you do if you don't become an orthopedic surgeon? I would still become an orthopedic surgeon, but there are some other options nowadays, which probably sounded boring in my lifetime because the technology was pretty basic. I would say probably radiology is a good one because you can have no procedures. We as doctors lost a lot of procedures. Let's say from what we call interventional cardiologists who used to do the catheters and the insertions, the radiologists took it. Radiologists sometimes they do some procedures on the brain or on the heart or on the limbs. That's one interesting topic came up. Plastic surgery become more advanced now with the technology. You get a lot of covering of reconstructive surgery, not talking about the aesthetic surgery, but the actual reconstructive surgery. Surgery in general, overall, I think if you decide one day when you become a doctor, you will feel whether you become either a surgeon or non-surgeon, i.e. physician, or you can decide to be probably less of a patient-facing, sitting in the background as laboratory doctor or as radiologist or investigator. You can have a short contact with patient like an anesthetist and you don't see them again, or an A&E. But once you get to probably year 4 medical school, you will have that feeling of, am I going to be surgeon, non-surgeon? Am I going to be hospital-based or non-hospital-based? And then probably you pick up the subject you like.
Okay, thank you. So we have had a few more questions. If nobody in the MDT can agree, who will ultimately makes the final decision?
Interesting one. So ultimately the decision is to the doctor who's looking after the patient. So let's say I've seen a patient who's got complex condition. I will take it to MDT if it's got complexity, previous operations, difficult to make decision. And then in the MDT, probably got 3 or 4 doctors at least. Often there will be a tendency towards one opinion. If it's 50-50 split, it will be pretty much your decision and ultimately really the patient decision. So your job as a doctor not to make the decision on behalf of the patient. You will give them the facts, say, look, I discussed your case, probably your chances of success with this type of treatment is 50%, and your chances of complication, i.e. make you worse, is about 20 or 30%. And he will tell you, and you can give him the information, it is a decision of the patient to make that decision.
Thank you. What's the longest surgery you've taken part in?
It's probably about 10-12 hours, I would say. Multiple fractures in one patient. I've done 12 hours in that guy I presented to you when I was in war zone. Probably that's the longest. I know there are some surgeries that take longer. Let's say in spine, sometimes correcting spine, and then they can have teams taking over from each other. But I think I was on my feet, the longest was probably 10 or 12 hours in one go. You don't feel the time, honestly, but you feel shattered at the end of the procedure.
And what drew you towards medicine to begin with?
That's quite interesting. You know, when you apply to medicine, you're often 17 years old. Probably in Syria, I did not have the opportunity to really have the work experience or to talk to many people. It's just a general concept of it as a humanitarian work. Other thing at the time, I already calculated that's medicine allowing to work in any part of the world. So for me, I always like to travel and go away and visit different parts of the countries, and, I never know where I'm going to end up, but with medicine, even with some equalizing exams, you can always find a job anywhere in the part of the world, and that was an important part of it. Interesting, I like anatomy. So physiology has always been challenging to me, and pharmacology. Anatomy has always been very good and exciting, and I like it. So I always remember anatomy very well. So as a surgeon, you'll be driven by the voice of anatomy. As a physician, you'll be driven by the voice of physiology. Probably that might be more leaning towards surgery later on.
Okay, thank you. So there aren't currently any more questions. I think if it's okay with you, we'll end the talk there. If there are any more questions, if you direct them towards the work experience inbox, I will then pass it over to Mr. Atassi, should any come in. Thank you all for attending.
Thanks everyone for listening. I hope you had an enjoyable evening, and best wishes for your career, really.